And people are joining. Hi, I'm Sarah Green. I'm the Executive Officer of the Association, and we'll just wait a minute or two to allow people to join before we kick off. Coming in somewhere. Okay, well, it looks like we've got 23 people online, which is great. As I said, I'm Sarah Green. I'm the Executive Officer of the Health Services Research Association of Australia and New Zealand. And I'd just like to start by acknowledging the traditional owners of the lands on which we meet and pay respects to elders past and present. The Health Services Research Association provides networking, education and training and builds capacity in health services research in Australia and New Zealand. These webinars are one of our key activities, and we try and run them at least once a month on leading health services and policy research and methodology. Webinars are free and open to members and non-members, but we do encourage you, if you're not a member of the association, to have a look at our website and our membership options and think about supporting us. We're always keen to hear from participants about other topics and speakers that you'd like to hear from. And particularly at the moment, if you have any suggestions about webinars that we might run around COVID-19, both in terms of research that's happening or might have happened in the past that's useful to the situation, or speakers you'd like to hear from about career issues and how we manage our research careers in this crisis, we'd be really keen to hear suggestions. Our other key activity is our policy and research conference, and we're lucky that our next conference is not scheduled until December 2021 in Sydney. So we do hope that things will be back to normality by then. The other thing we do regularly is issue a newsletter, and at the moment that's very COVID-19 focused, and we do have on our website a resource that we're trying to keep up to date with all the relevant links and research around that topic. And again, if you have anything that you think will be interesting to the research community, do send it in to me and I'll have a look and see if it should go up on the site. Couple of housekeeping issues this morning. You should be able to see the slides and hear Kristie's presentation, but we can't see or hear you. But if you move your mouse around, you'll get some icons at the bottom of the screen, and there's a chat button if you've got any comments while the presentation is going along. And if you have any questions for Kristie, you can type those in the Q&A button. The presentation should take about 30 to 40 minutes this morning, and then we'll have about 10 minutes at the end for questions, and the chair will put those to Kristie at the end. We're recording the presentation, and that should be up on our website in a day or two. And I'm going to hand over now to Suzanne Robinson. Suzanne Robinson is a Professor of Health Economics at Curtin University, and she's a member of the Association's executive team, and she's going to introduce Kristie and manage the webinar this morning. Thanks, Suzanne.
Thanks, Sarah, for that great introduction to the association. Welcome everyone, and good morning. I think it's still morning over in the eastern coast, side of the coast country. Before I begin, I'd also like to acknowledge the traditional owners of the land and pay my respects to elders past and present. So we've got another interesting webinar session today, and it's a great pleasure for me to chair the session. I always do enjoy chairing these sessions. So welcome to Kristie Weir, who's a PhD candidate at the University of Sydney School of Public Health. The association is really always keen to support our PhD and early career community. So really fabulous, Kristie, to have you here today. And your topic's really interesting and important, and something I'm interested in. So I was happy to put my hand up to chair this one. For those of you who are new to the webinar, I didn't just come in and didn't catch what Sarah said. We present for around 30 to 40 minutes and open up for questions. Feel free to post questions as you go, and I'll filter through and ask Kristie the questions at the end. I really do encourage you to ask some questions. It's great for the other participants, but also great for Kristie to have a nice friendly audience to ask questions and to get her to think a little bit more about her research. So by way of introduction, Kristie is a researcher in the Sydney Health Literacy Lab and a member of Weir Healthcare. A PhD involves developing and testing a communication tool to support patient involvement with older adults in the context of polypharmacy. She's got a background in science and public health. She completed her Masters of Public Health in 2016 at the University of New South Wales, and in a research interest focused on health communication and decision making to promote patient involvement and appropriate prescribing of medications for older adults. The title today is on the slide, so I won't read that out, but this is part of the PhD research, and it's, I believe, a particular paper. And Kristie, if time, will also open up and just talk a little bit about the broader PhD. So at this point, Kristie, I'm going to turn off my video and hand over to you to present. Thank you.
Thanks, Suzanne, and thank you, Sarah, for the opportunity to host this webinar and present on my work. So, as Suzanne said, I've just actually submitted my PhD, and I'll be talking about some work that I've done as part of that. So the title of my talk today is Decision-Making Preferences and Deprescribing, Perspectives of Older Adults and Their Companions About Their Medicines. So briefly, a little bit more about me. I'm a public health researcher in the Sydney Health Literacy Lab, and we were based in the Sydney School of Public Health at Edward Ford Building, but we're now at home. And I would just like to briefly acknowledge the Apple team, which I worked with on this project, to Debbie Rigby, Andrew McLaughlin, Carissa Bonner, Stacey Carter, Lyndall Trevina, Les Erwick, Jim Colvin, and Isabel Baker. And importantly, I'd like to acknowledge the older adults and their companions who participated in this study, and my supervisors that have helped and everything they've done along the way.
Hi, sorry, Kristie, can you just maybe move a little bit closer to your computer?
A bit closer, yeah.
Sounding a little bit, sounding better earlier when we, yeah, thanks.
Yeah, is that a little bit better, the volume?
Yeah, it is.
Okay, I must be rocking back on my chair or something. How's that? Okay, I'll give that a go, but just, yeah, pipe up if my volume goes down again, and I'll try and do something about it. So briefly, an outline of my talk. So I'll be discussing my qualitative paper, which won the HSRAANZ Qualitative Paper Award. And I'll be going through the introduction, the aims, methods, results, discussion, strengths and limitations, and also the conclusion. And if there's time afterwards, I'll briefly touch upon a couple of other studies that I've conducted as part of my PhD, which is relevant, but we'll see if we get to that point. So here is the paper that I'll be talking about. To let you all know, it is open access, so you can, even if you don't go through a university library, you can access that via the journal. It was selected for a special issue on qualitative methods, so that's why it's open access. So just a bit of background. Inappropriate polypharmacy significantly increases the risk of side effects, adverse events, cognitive and physical impairment, and hospital admissions. There is increasing attention in the academic literature and mainstream media for the dangers of polypharmacy and how this can be reduced by deprescribing inappropriate medicines. In our work, we define deprescribing as the systematic process of identifying and discontinuing or reducing the dose of medicines when harms outweigh benefits within the context of an individual patient's care goals, their current level of functioning, life expectancy, values, and preferences. So this is an important challenge of modern medicine. 2/3 of older Australians who are aged 75 years and above take 5 or more medicines every day, and we can define this as polypharmacy. So 55% of older hospitalised patients, that was in a study of 534 older patients, were taking 1 or more inappropriate medicines. So a potentially inappropriate medicine might be harmful or unnecessary. And these kinds of statistics can vary on the way a potentially inappropriate medicine is identified. So in this study, they were identified using a common tool called the STOP criteria. In a report that recently came out by the Pharmaceutical Society of Australia, they found that 250,000 annual hospital admissions are a result of medication-related problems. So it's a huge, huge problem. Sorry, I've lost my mouse. So with older people taking multiple medicines, they're often not aware of the reasons for taking their medicines or for the potential side effects. Also, a previous study has found that among people aged 75 years and above, there's wide variation in their understanding of benefit and harm information. So the risks of harm are higher for older people with multiple health problems and those who are frail. An older person taking multiple medicines, especially 5 or more a day or polypharmacy, are more likely to experience medication-related harm. So if we want to minimize the burden of multiple medicine use, it is essential that older people are involved in decisions about starting, stopping, or reducing medicines. In an ideal situation, this would mean that an older person knows what medicines they are taking and why, discusses how they feel about their preferences relating to their health and medicines with their clinicians. They talk about the potential risks and benefits about medicines, and also they participate in making final decisions about their medicines, which is a process referred to as shared decision-making. So shared decision-making has been identified in clinical deprescribing protocols and in other work that is being done in the deprescribing sphere. And this is in acknowledgement of the importance of talking to patients about their medicines, involving them in decisions, and taking into account patient preferences in order to optimize the patient's medication regime. However, there is a body of literature that demonstrates clinicians may be reluctant to initiate discussions about deprescribing with their older patients. There is a belief held that older people would resist deprescribing, that they highly value their medications, and that raising the topic of deprescribing might imply the clinician is giving up on their patient or withdrawing care. It's clear that patients and clinicians are generally more familiar with discussing the initiation of a medicine rather than stopping it. Older adults vary in the extent to which they want to be involved in this dialogue. However, it's very important to still at least attempt to involve older patients in these kinds of discussions. And older people's involvement in these types of decisions can depend on various things such as their health, knowledge, and information preferences, their relationship with their clinician, and their beliefs and attitudes towards medicines. So although many guidelines exist to help patients and clinicians make informed decisions about initiating a treatment, there is little guidance on how to communicate about not starting, tapering, or stopping a medication or deprescribing. So the aim of my study was to explore the experiences and attitudes of older adults and their companions towards making decisions about medicines and their thoughts on deprescribing. The methods for this study, it was a qualitative study, and we used semi-structured interviews. We recruited older adults who were aged 75 years and above, and they were taking 3 or more prescription medications. We also recruited their companions, and the way that we recruited older adults was through 2 avenues. Firstly, through GPs, so through their general practitioner, GPs invited their older patients to be involved, and also through a rehabilitation ward in a hospital. We did this so that we would be able to recruit older adults with a range of health statuses, so that we wouldn't only recruit the more healthier or younger older people. The interviews were conducted face-to-face in the participants' homes. They ranged from around 30 to 60 minutes. And the interview involved open-ended questions using an interview schedule. And we also had a brown bag review of the patient's medicines. So the way that we did that was we asked older patients to bring their, have their medications on the table or have them ready for when we came by to do the qualitative interview. And then we went through their medications one by one with the patient. So the analysis we conducted, it was a thematic analysis of the transcribed interviews, and it was conducted to describe and illustrate the range and depth of patient experiences and attitudes. The content of each interview was summarised and compared using a framework approach, which is a matrix-based method for managing and analysing qualitative data. So 30 older adults were interviewed as part of this study, and this table shows their demographics. We had a fairly good mix of male and female participants. We had 9 patients who were over 85 years of age, and their ages ranged from 76 to 98 years old. There was also a range of highest education that they'd obtained, and the majority were taking 5 or more medicines, and 9 were taking 10 or more medications every day. So as you can see with the Charlson Index, which is looking at comorbidities, there is a range of how many older people have, which is an indication of their health status. However, one of the patients, we didn't obtain their Charlson Index. There's also generally a range of their self-assessed quality of life. So here are the demographic information for the 15 companions that were interviewed. So for the companions who were interviewed, the majority was a partner of the patient. Some were their children, their adult children, and there were also other companions, which was the paid carer and cousin. So for the participant demographics, about half lived on their own at home, and 19 lived with someone, so their companion. So this is a summary of the main themes. The main themes I'll be talking about today center around, firstly, medicines, attitudes towards medicines, knowledge and understanding, including perceived knowledge and understanding of their medicines, and experiences such as with side effects. Secondly, preferences for engagement and decision-making, being involved in decisions about medicines, and the quality of the patient-doctor relationship as perceived by the patient. Thirdly, participant characteristics such as self-reported quality of life, length of time taking medications, and comorbidities and the role of the companion will also be discussed. And all of these themes will be reported in light of an older patient's willingness to deprescribe. So this is a figure from the paper, and it shows 3 different patient types that emerged from the data. And they varied in regards to attitudes towards medicines, which is along the top line, attitudes towards medicines, whether or not they would consider or be open to deprescribing, and also their decision-making preferences. So, sorry, actually that's down the side on the left. So I'll just go through the types. So you can see in the circles at the top of the figure, the one on the far left is type 1. So they appeared to be more attached to their medicines and highly valued them. They generally had negative or ambivalent, negative attitudes towards deprescribing, and it could be disinterested or more towards very resistant. They tended to have a high trust in their doctor, and preferred to be informed about their medicines or their health or their conditions, but ultimately seemed to leave decisions to their doctor. So with type 2, they tended to have more ambivalent attitudes towards their medicines. So they seemed to value the benefit of medications, but tended to dislike the side effects or the hassle of taking them. They were generally willing to consider deprescribing and were informed and aware of deprescribing options. And some of the type 2 patients seem to prefer a shared decision-making style. For the type 3 patients, they seem to have mildly positive attitudes towards their medicines, but didn't generally give medicines too much thought and were unaware that deprescribing may or may not be an option. So now I'll just go through these 3 types in a bit more detail. So these are, as you can probably guess, these aren't real patients. So these are more personas of the 3 different types of older patients that emerged. And some patients did tend to move between some of the different types, but generally seem to fall within one of those 3, although they weren't always mutually exclusive. So these personas, firstly was Valerie, valued her medicines. Type 2, Sybil, open to deprescribing. And Des was less engaged, and I'll go into more detail about them. With type 1, Valerie, here is a quote from one of the type 1 patients. So well, I keep going. I don't know what will happen if I don't take them. So generally, patients like Valerie in type 1 appeared to be very positive towards, had very positive attitudes towards their medicines, and genuinely believed that medicines were keeping them alive, and also tended to assume that taking medications is an inherent part of aging or an inherent part of life, and that they tended to assume that everyone takes medications once you reach a certain age. This group tended to express more resistant views towards deprescribing, and this could range from skeptical or negative, or also more concerned about what would happen if they stopped a medication, and could be quite fearful of those consequences. Patients in this group tended to be more engaged in their healthcare, and that could look like asking questions of their doctor, openly volunteering information about their health and medications, or voicing any concerns that they may have. They tended to have high trust in their doctor and believe that their doctor already knows their preferences and their thoughts about different things. However, this group did tend to ultimately leave decisions to their doctor, but preferred to be informed about those decisions to be made. This group tended to have mixed experiences with side effects. So some had fairly major reactions, some had minor side effects, and some had reported they had experienced none at all. Most in this group rated their quality of life as good or above, and this group tended to believe that medicines played a role in their good quality of life. So type 2, or Sybil, I wasn't happy taking them at all. I couldn't function at all, not properly. So I stopped taking them. So this group tended to have both positive and negative attitudes towards their medicine. So it could be contradictory or conflicting. So generally, this type 2 expressed the view that they preferred not to be on medicines, but acknowledged the value in taking medications, but tended to wish they didn't have to take them, or looked for possibilities to take fewer. They tended to be generally willing to deprescribe, and some would actually instigate this or initiate this with their clinician and ask to be on less, but some really just accepted the medications that they had to be on. This group tended to be fairly engaged in their healthcare as well, so reported having high knowledge or understanding of their medications. They appeared to be aware of the side effects of their medicines, and knowledgeable about which ones they're on and their conditions. And were also fairly confident in accessing information about their medications or their health. So in regards to decision making, generally this group tended to want to be involved in decisions and to have shared decisions, and some participants in this group were really wanted to have that final decision for themselves and would consider the doctor's opinion or their advice. So this was the only participant type where some were involved in decisions about their medicines to the point where they would make that final decision themselves or share it with their doctor. So this might be related to the fact that more patients in this group were experiencing side effects, and this might have acted as a trigger to discuss medicines and make decisions around deprescribing. And most of the patients in this group had experienced side effects to some extent, or had been aware and identified side effects of medications that they were experiencing. Generally, the patients in this group rated their quality of life from fair to excellent, so there was quite a range, and reported higher self-rated health than the other groups. Regarding the relationship with their doctor, so patients in this group did tend to trust their doctor, but also seemed to be comfortable enough to ask questions about their medicines or to question their doctor if something was happening that they weren't very happy about, or something was they weren't comfortable with, and so forth. They volunteered information about their health, but there were some patients within this group that didn't share everything with their doctor because they could, they thought the consequences might not be exactly what they wanted around that. So some tended to really decide upon which information to share with their clinicians and which ones they didn't. So patients in this group tended to be more likely to live alone or have companions that did not seem to play a huge role in their health. So with these interviews, either the patient mentioned their companion might be less engaged, or their companion was not mentioned much at all during these interviews. So the third type, the persona dares, I'll let the doctor decide for me. I mean, I just presume that they try to do the best for you. Patients within this group tended not to have a strong attitude for or against medicines. They seem to take medicines because they're told to, and also seem to assume that everyone takes medicines, so they just would accept that. Most of the patients in this group tended to be open to the idea of deprescribing, particularly if it were suggested to them by their doctor. So sort of easy come, easy go with the medications seemed to be their attitude. So most of the patients in this group tended not to be very engaged in their healthcare or particularly involved in decisions. And it seemed to be perhaps a combination of less interest or lower perceived knowledge about lower perceived knowledge or understanding in regards to their medicines. Most of the patients in this group reported that they had no experiences of side effects. And this is quite interesting because the patients in this group were on a high number of medicines, with the average being around 9. So it's surprising that none were experiencing any side effects while they were taking 9 concurrent medications. And most of the patients in this group they said that they had been taking medications for a long time. The majority of patients in this group were male and were more frail in regards to having 3 or more comorbidities and taking high numbers of medications. So they also reported their self-rated health to be poor or fair. So it was lower than the other groups. And their companions played a much more important role in terms of managing medicines and helping with everyday living. So with regards to being less engaged or involved in decisions about their medicines, this group tended to explain their involvement preferences by saying that they would prefer to just follow the doctor's advice and they want to do the right thing by their doctor. So expressing disagreement or having a negative attitude about a medication or their experience with it was kind of seen as not following the doctor's advice or not doing the right thing by their doctor. So that played a role as well. So now I'll just go through some of the themes that emerged from the companion interviews. Something I didn't mention in the methods was that patients and companions were interviewed together at the same time during the same interview, and companions were encouraged to answer questions at the same time as well. So this is a quote from a companion who had a patient who was type 1. So the quote goes, "If you're responsible, you take medications in order to prevent things going wrong, don't you?" So for partners with patients who appeared to be type 1, there was more of an equal partnership, or the companion may be more dominant in that relationship. And they tended to hold concordant views with the patient that they cared for in terms of having very positive attitudes towards medicines, and that quote reflects that. So for a companion with type 2 patients, and the higher the dose, the less mobile you are, and you become in another world, just like an ordinary drug addict. So the companions in this group tended to have more of a collaborative approach with their patients. They seemed to support their patient companions to be more independent, to be aware of their medicines and actively involved in their care, to maybe encourage the patients to be more knowledgeable about their medicines, to take ownership of their health and that type of thing. So for companions who had type 3 patients, here is a quote: "Every time I'd go to visit mum in the hospital, she'd say, 'They're giving me this or that one, is that right?'" So for companions in this group, they tended to play an important role assisting with everyday life, and it seemed to be a much more important role than some of the other groups. They seem to have complete management of medications and really be very hands-on with the management of medications. And with some of the patients in this group, it was to the point where the companion was really the only one who knew which medicines the patient was taking and why. But all in all, with the companion interviews, they tended to marry up with the attitudes and experiences of the patients. So in general, for the discussion, we identified 3 subtypes of patients that may communicate differently in the context of medicines and deprescribing. So consultations with GPs, specialists, pharmacists, they're all great opportunities to actively involve older people in decisions about their medicines. However, shared decision-making in this context, although it's very important, it's not easy, and there is little guidance on how to do it. And it's important to recognise that it can be challenging for both clinicians and older people. And older people with comorbidities are a complex group and are often treated by multiple physicians. They may be in and out of hospital, and clinical guidelines are difficult to interpret for this group, which also adds to the difficulties of approaching these conversations. That's another reason why it's important to respect an older person's preference to be involved, to be more involved or less involved in these kinds of decisions. So previous quantitative research in this field has found that high levels of willingness to deprescribe reported by patients. However, our results are more mixed. I mean, we're not entirely sure why, and it's not great practice to compare quantitative findings with qualitative findings. However, it's good to sort of think these types of things through, and perhaps it could be that the people in our studies, ranged a little bit more in terms of how healthy they were, although that probably wouldn't explain all of it. And also our study highlighted, has highlighted the variation in older people's attitudes and the factors that may influence this, including their knowledge and medicine. So that's still an important contribution. Perhaps the minimum requirement for shared decision-making in this context might be to establish awareness of the option to be involved and to create the circumstances to support older patients to be involved as they prefer to be, and also to discuss the patient's goals and preferences over time as they may change. So of course, when a patient's life changes, their circumstances change, but also to touch base again about the medications rather than having them continue for long periods of time and not coming back to those sorts of decisions. And also, if the patient is interested, to create circumstances for being involved in decisions. However, it's really important to think about the strategies to support these types of conversations, because just saying this is something that should happen, doesn't take away all the challenges or barriers that might come along with that. So here are just some possible strategies for having conversations with the different participant types. So we know from the literature that communication strategies can be helpful in supporting conversations and shared decision-making with older people. And so some of those strategies might be around exploring patients' preferences and goals, exploring their receptivity to deprescribing, or discussing their values and also the trade-offs between different decisions, and also discussing the harms and benefits of medication so that decisions are able to be made. So the subtypes we identified may require tailored communication strategies to meet the needs of individual patients. And here are some suggestions for how we might support clinicians and patients to have these types of discussions for the different types. So for Valerie, an idea could be to discuss a time frame for medications, particularly when a medication is initiated or started. This might help to, I think sometimes clinicians may say when a medication is started that the patient will have to take this medication for the rest of their life. So when deprescribing is suggested or brought up as an option, that might really create a lot of fear or anxiety around why that medication might now be stopped. So of course, if a patient has been taking a medication for a long period of time, it would be easy to attribute great importance to that medication. So perhaps with Valerie, having a time frame for medications in the beginning, also using opportunities to bring up deprescribing in a safer way or over multiple conversations might be helpful. But it also would be really important to address emotions or fears or concerns that might come up if a clinician does suggest to reduce or stop a medication. So for Sybil, type 2, perhaps not starting a medication might be an option, at least in the beginning, for this group of patients that did tend to be more towards open to deprescribing and reducing the number of medications they take. And also discussing and embracing uncertainty around the evidence, and particularly as that changes. So for many GPs, they might see their older patients over many years or even decades. So having an open and frank discussion about what is not known in the literature or in the evidence that these medications are based upon would be really important for Sybil and patients like her. and also reviewing medications and revisiting decisions over time to check that they're still in line with what the patient's goals and preferences are would be really important too. So for DES or type 3, some communication strategies might be around asking open questions and having empathic responses and encouraging patients that their input is really important, that they are an expert in their own health and in their own experience of their medications and their conditions. And it's not just the clinician who should be having input as well, but also allowing patients like Des to be less involved if that is what they need and that is what they want to do. So one option might be to discuss the potential harms of medications. So if a patient is on multiple medications, they might be more aware of what could be a side effect to a medication and what are other things, rather than sort of having a side effect of a medication to be mislabeled or misdiagnosed. And also to look for opportunities for deprescribing, particularly when patients in this group, and I guess also for Valerie and those in type 1, at least for many patients, they will follow their doctor's advice regarding deprescribing. So that's really important too. So just briefly, the strengths and limitations of this research. So a strength is that we recruited in 2 different ways, so that we did have a heterogeneous sample of patients and companions in regards to education level, number of medications and their comorbidities. And with their health statuses, they varied. And so some patients were more robust or frail, and we had a large age range that we recruited as well. Although, of course, age doesn't necessarily go along with whether or not you're robust or more frail. So some limitations for this research. So we did have some recruitment challenges, but we did overcome those. So some recruitment challenges involved when we were recruiting patients through hospitals. By the time we had gone out to conduct the interview, or by the time the patient had been discharged from hospital, for some people, their health had declined. And so generally, recruitment in these types of areas, when you are trying to get a range of how healthy people are, it can be tricky in that sense. Also, most of the patients who were involved in this study did report having a long-term positive relationship with their doctor, which might not represent all patients' experiences. And to note, the involvement of companions in some of the interviews might have influenced the patient's responses. However, we only ever included companions in interviews if that reflected the normal environment of the patient and companion. So it would have reflected how they went to the doctor's surgery or how they interacted. So in conclusion, communication strategies may support conversations and shared decision-making with older people about their medicines. So I've already touched upon different communication strategies that might be helpful. And it's always good to keep in mind exploring patient preferences and looking for opportunities to deprescribe and to talk to patients about that, as well as discussing patients' goals and preferences and trade-offs regarding medications. So as I've said, different types of patients might need different strategies. However, it's really important that quantitative research be conducted in order to potentially verify this typology and try to have a look at maybe the percentage of older adults that fall into the different types. However, what else might be helpful? So different things could be helpful, such as communication tools like scripts or decision aids or conversation guides in this context. So if you'd like, Suzanne, I could pause there and answer any questions that people might have. And then if there's time at the end, I could provide a brief glance forward the studies that I've done.
Yeah, that sounds absolutely fine from my perspective. We have got one question up so far, so if other participants, and I've got quite a few questions that came up as you were speaking in my mind. There's 2 questions now, so if other people, I could encourage you to pop some questions up there, that would be great. So Janet asks, did patients or carers discuss getting information about their medicines from pharmacists? And just before you answer, I mean, I had a thought, you know, in fact, who are the people they're having their discussions with, and are pharmacists within that clinical group?
Yeah, so we did speak with the patients about the pharmacists being involved, and so for quite a few of the patients who were involved in this study, they did consider their pharmacist as a great source of medicines information. And with several patients, they had a setup already with their pharmacist, so somebody that they'd been going to for many years. They might have their medications delivered, and that was another person in their care team that they trusted in order to have their medications delivered. And there was very good rapport for many of the patients that talked about their pharmacist. We also asked patients whether or not they'd had experience with having their medications reviewed. So some of them did mention having a medication review by a pharmacist, but really not many. It tended to be more medication information and dispensing, and as another person in their care team working with their GP. And with your question about when are they having discussions, or who are they having discussions with? So for most of the interviews, older adults tended to draw upon the experiences they'd had with their GPs, but also quite a few would talk about having discussions with their specialists. So some had a lot of involvement from specialists like cardiologists or other types of specialists, geriatricians as well. And some did draw upon experiences they'd had in hospitals. So they would talk about hospital physicians or nurses where their medications had been stopped or started again, and different experiences they'd had. So they really did tend to have a lot of contact with the health system and different multiple providers. But who they trust and who they felt comfortable enough talking about deprescribing or sharing their views did vary amongst the patients.
Yes, which is a really interesting one, isn't it? And thinking of the system impacts. So if you've got chronic, you've got lots of chronic conditions, so you've got co-occurring, and it's interesting to think about how that's all structured. And I know discussions I've had with GP colleagues, and I was thinking about your participants who weren't necessarily wanting to have any discussion and quite passive in that decision making, and people were on 10 medications. The GPs would say that they would not touch medications if someone, a few people I've been working with would say they wouldn't even look at changing any medications without a specialist's agreement, because they just felt that it was, so many different impacts from the different types of medications. So then that would be not a decision-making discussion they could have with the patient, but more or less pass them back to specialists or get the pharmacist involved. And I suppose then that's about team-based and working around with the patient. So the whole system impacts on how decisions are made is probably where I'm going to.
Yeah, no, absolutely. It really does. And I think even some of the patients in this study did talk about saying how if their GP did suggest deprescribing a medication that their specialist had started, and they did have a very trusting relationship with their specialist, and even they would disagree with their own GP about having some medications stopped if the specialist started it. So it's complicated. It's not necessarily a hierarchy, but it does there are different roles and responsibilities that are coming through for GPs and different multiple providers. And it's a shame that it might end up being that the patient then has to go to different ones and try to be that person in the middle, but having rather a team-based approach could be.
I suppose the other bit of that, which would be interesting to study, would be around how information is shared across those different settings. So I know when specialists are referred, where a specialist refer back, or sometimes a specialist will not be expecting the patient to stay on that medication for a long time, but expecting the GPs to take them off, and that's not communicated. So I think there's something in the whole communication aspect across the different services and providers, making the patient key in all of that, of course.
Yeah.
Okay, another question from Sharon is, any tips for identifying the type of patient?
Yeah, tricky. That's a good question. So since this work, we have done very preliminary work in trying to condense this typology into 3 or 4 dot points and asking patients to select which one they identify with most. So that we haven't got the results of that study back yet, but that is one possible way of doing it, is having sort of just a few dot points of these types of personas that I've presented to you, not with pictures and things, but just with more a summary of the different types, and having a patient select which one they identify with most. Could be one way of doing it. Another way you could do it is to have the GP or a clinician that knows the patient well kind of get they might already have a sense of which type the patient might fall under, but you wouldn't want to get too much into sort of presuming that a patient is more like this or more like that. However, when I presented this work, and my colleagues, my supervisors have presented this work to different clinician groups like GPs and specialists and so forth, there has been a lot of anecdotal feedback that they do see these types of patients on a day-to-day basis in clinics, which is interesting. But I think the way to identify which type of patient might be is sort of a few steps further on, and would require a lot of, I think it might require a bit of trial and error in testing different ways that could be done usefully, and also checking in a quantitative way how that really falls into place.
Thank you. Another question from Nashwa was, how did you develop the questionnaire? Also, did you have conflicts between carers and patients? So 2 questions, and one about the development of the questionnaire, and then about any conflicts you might have had between patients and carers and patients.
Yeah. So how we developed the interview schedule?
Yeah.
So it's a qualitative interview schedule. So we started off by having sort of a general research question and an aim of what we wanted to achieve. And the way that we developed it was with our multidisciplinary team. So the people that I acknowledged at the very start of my talk, so they have backgrounds in pharmacy, general practice, epidemiology, psychology, shared decision-making, and geriatrics as well. So it was very important to have input from all those different fields. And most importantly, from a consumer who was an older gentleman taking multiple medicines. So it was really important to have all that input from him as a consumer and all the different specialties as well. So that was how the initial interview schedule was developed. And then it was pilot tested with, I think, 2 or 3 different older patients. And another important thing that was in the interview schedule, which didn't come out in this presentation, was that after doing the brown bag review, we did talk patients through a vignette, which is like a story, to see how a patient might identify with that story. And the story was designed to help patients think about trade-offs between a medication that might be causing them to feel dizzy and whether or not they would talk to their GP about deprescribing that medication, whether they'd stop it, and how they would make that decision based on this medication might lengthen their life, but they might have a reduced quality of life because they were feeling dizzy, or however the vignette went. So that was another very useful way to go about the interview schedule, was to get, and that really did help older patients to think about those types of decisions when they might not have been able to give an example of their personal experience.
Excellent, thanks. Just one last question, I think, because we're getting close to time, and it's from Tara. Officer. And did you consider patient compliance with medication and how this influenced the desire to deprescribe? So it's around compliance and people's preference around deprescribing.
Yes, so for the group of patients who fell into type 2, some did talk about how they had been less adherent or less compliant with the medications that they'd been prescribed. And so if they had experienced any side effects, they did talk about how they just stopped it. They didn't ask permission from their GP beforehand, and they did just stop that medication. Some then went on to talk to their GP about problems they'd had with the medication, but some didn't. Or there were also instances of patients maybe taking less of the medication that they were supposed to take because they did report that they felt funny or a bit strange when they took a medication. So there were instances of when a patient was less adherent, and it did vary whether or not they did talk to their GP about that. And I think that was really that variation seemed to be related to the patient themselves and perhaps how confident they felt to talk to the GP about that, and also the consequences that they felt they might happen, whether the medication might be stopped if they wanted that or not, but also if their GP might be unhappy that they did that. So there was trust could also work in two different ways in that sense, but they were very forthcoming with all their different experiences with it. But yeah, I hope that answers the question.
No, it does, and it's an interesting, could be quite an interesting quantum qual question there if you can get data on compliance going forward. We are unfortunately close to time, so there are a few more questions, but I'm sure that Sarah will be able to pull the questions and let you have those, because it's always interesting to see people's interest. And if people wanted to email you, I'm sure you'd be open to answering a couple of the questions, to support. So it just comes back to me to say thank you very much. That was a really great presentation, very clear, and it sounds like a very solid piece of work. So thanks for that, and good luck with the PhD you've submitted. So let's hope you have some critical friends as examiners and you get some good feedback, and look forward to seeing more of the published work. So well done on this publication. Just thanks for the audience for your contribution, and Sarah Green, our exec officer, as ever, she does an absolutely fabulous job in organising and keeping us all on task and the technical support. Can I just direct you to the website, which outlines details on our webinar series and more details on events and conferences. And if you're not a member of the association, I'd reach out and say there's no time like the present time to join the community. It's a great community to be part of. For me, that's just enjoy the rest of the day. Thanks again to Kristie for a great presentation. Stay safe and look forward to seeing you on one of our events very soon. Thank you all. Thanks, Kristie.
Thank you.
Thanks,
bye.
Have a good day.